Hi, my name is Connie Koklanis and you're watching a video on the management of microtropias. As we mentioned previously, almost all patients with a microtropia will have a anisometropia. So it's important that one of the first things you do is manage the anisometropia. It is suggested that perhaps if you detect anisometropia early on, you may prevent microtropia from developing. There isn't a strong evidence to suggest that, but given that we think there is a strong link between the two and there may be a causal relationship, it is strongly suggested that you manage anisometropia as early as possible. In terms of occlusion, these children will have amblyopia. It tends not to be dense amblyopia, but you will need to manage the reduction in the visual acuity. Now, because they have a small angle esotropia, excessive dissociation of a patient can lead to the breakdown of the control of that microtropia. Patching is a dissociative treatment method, so you have to be careful with how many hours of occlusion you prescribe in a patient with a microtropia. You do not want to be prescribing all-day occlusion, for instance, in a patient with a microtropia. If you do this, there is the risk of the patient breaking down, and when they break down, what it means is they'll go from a 10 prism diopter esotropia to a much larger esotropia. It may even be 50 prism diopters, for example. And at this point, they'll experience diplopia because they've never had a large angle strabismus before. So be careful with the amount of occlusion you prescribe. I tend to prescribe 2 to 4 hours maximum in patients with a microtropia. Now, another thing to point out is that it appears to be very difficult to give patients equal visual acuity when they have a microtropia. So it's not often that you can get to 6 visual acuity. So just be aware that it is highly likely that the best outcome you'll get is a one-line difference at the conclusion of your occlusion therapy. Now, in terms of orthoptics, we don't generally prescribe orthoptics in patients with microtropia unless there are issues with the control of the latent component of the deviation. So in other words, there is a foria is decompensating. Children tend not to have this issue, and as such it's usually adults who've had a microstrabismus as a young child who may present with a decompensating associated esophoria. If this is the case, then you'll be looking at giving them divergence exercises. So you're looking at basing prisms or negative relative fusional divergences as an example. And finally, in terms of surgery, this is contraindicated. We do not recommend surgery in a microtrope because 1, it's cosmetically very good, 2, the patient has BSV, and 3, if you operate on this patient, you run a high risk of overcorrection given the size of the deviation. So there's really no reason to perform surgery on these patients. They have a cosmetically acceptable small angle strabismus with BSV. Okay, that brings us to the conclusion of this video. Thank you for watching.